Wonderful. Thank you so much all for being here, and thank you, Shirley, for that introduction and just organizing this. It's my pleasure to be a part of this absolutely wonderful panel. And also, I just want to thank every one of you who is here today on a Sunday morning, spending your time here with us and learning more about migraine and all the other associated conditions and comorbidities with it. So migraine is a disease that rarely comes alone. And for many patients, it exists alongside many other chronic conditions. This can include obesity, sleep disorders, mood disorders, and chronic pain. These conditions are not separate. They're deeply interconnected and often driven by the same pathways like inflammation, hormonal changes, and disruptions in appetite and metabolism. For patients, this creates a daily challenge, not just one in managing one condition, but balancing many of these all at once, often without a clear guidance on where to start. Today's discussion is about connecting these dots. We'll explore the relationship between migraine and obesity, why they so frequently co-occur, and what treatment options we have, both medical as well as integrative, to help address both of these conditions. Most importantly, we will focus on practical tools and resources to help patients navigate these overlapping conditions in real life. And so first, migraine rarely exists alone. Dr. Halker, let me ask you, do we know why migraine rarely occurs alone? And what are some of the other comorbid conditions that can occur with migraine?
Thank you, Dr. Tannen. Hello? Hello? Okay, no. Oh, yeah, okay. So I had to turn the mic on. It's helpful, yes. Well, good morning, everyone. I'm so happy to see such a great turnout for this really important conference. And it's a really important question. As you heard, I'm a physician here at Mayo Clinic. I take care of a lot of people who live with migraine. And as many of you are well aware who live with migraine, it's really not a condition that you experience in isolation. Migraine is a condition I think that many of us who have it experience with many other problems as well. And I think there's many reasons for this. So for example, we know that migraine is a genetic problem. It's a problem of pain transmission. So one way I share this with my patients is that, if we translate this to computer language, you can have like a hardware problem with your computer, or you might have a software problem. And we using that analogy, migraine is more of a software problem. So that's why typically MRI scans can't show migraine, right? And along those lines, different things can also impact migraine or coexist with migraine as well. So many other conditions can be seen in someone who also lives with migraine. This can include things like sleep problems, like sleep apnea, pain in other parts of their body, like fibromyalgia, for example, or mental health conditions like depression and anxiety. And there can be many reasons for this. So sometimes it can be genetic. Sometimes it can be inflammation, as we have heard about and we'll be discussing. But I think there's many other layers to this answer as well. For example, if someone is, if they have many migraine attacks, that can disrupt sleep. And that can have a bidirectional, response, and that can then go back and worsen their migraine experience as well. If someone is having frequent migraine attacks and that's not allowing them to live life the way that they really want, not allowing them to, interact with their family or to participate in their job, well, that can have an impact on their mental health. Well, then that can feed back into migraine, so there can be a bidirectional response in that way. So I think there's many layers to this. And then let's not forget the impact of medications. So many medications that people take can be life-saving, right? So mental health is a real problem. And many medications that are used to help with mental health can have things like weight gain as a side effect or head pain as a side effect. And sometimes some of the medications that we use to help with migraine can have other medical problems as a side effect too, including causing weight gain or disrupting sleep. So I think it's actually very complex as to why many medical problems go together.
Thank you so much, Dr. Halker. And yes, I completely agree. I think it's such a complex condition and all of these different things that go together that we all need to address together. And one of these things that bothers a lot of people is obesity. So, Dr. Stamford, as one of the experts in obesity, can you speak a little bit more about what is obesity and what is its relationship to migraine?
Absolutely. And actually, it's a delight to be here. I'm sorry I can't be with you in person. I'm actually in Chicago, which is not where I'm usually based. I'm usually based in Boston. So it's a delight to be with you today. So let's talk about obesity, which is a chronic relapsing disease characterized by excess and dysfunctional adipose tissue. And that's just a fancy word for fat tissue, but fat is actually an organ, which is adipose tissue. And that releases inflammatory chemicals that affect the brain metabolism and is critical for migraine patients in this trigeminal vascular system. In patient-friendly terms, your body fat is not inert storage. It is a biologically active tissue that can worsen migraine through inflammation, much like was just mentioned. And that link between obesity and migraine is this bidirectionality that we just talked about, and it's mechanistic. So excess adipose tissue elevates something called the calcitonin gene-related peptide, or CGRP. And this key neuropeptide in migraine pathophysiology also increases pro-inflammatory adipokines, which are leptin, IL-6, and TNF-alpha. IL-6 is interleukin-6, TNF-alpha is tumor necrosis factor alpha. And these lower the threshold for migraine attacks and promote progression from episodic to chronic migraines. Notably, weight loss, whether through behavioral intervention or through things like bariatric surgery, actually reduce migraine frequency, severity, and disability, which benefits really happen before you actually achieve significant weight loss. This suggests that there is metabolic and inflammatory mechanisms beyond simple weight reduction. And I think this is really important. So when I'm explaining obesity with migraine, it's important to get over some old misconception and look at some patient-friendly realities. So let's look at some old misconceptions. There's a lack of willpower or people are just eating too much. Let's go to this really patient-friendly reality. This is a neurobiologic disease where the brain defends a higher body weight set point, and weight regain is physiologically driven and it's not a personal failure. I think this is really important for people to understand as I'm working with patients with obesity and patients with migraine. This is really, I think, the most key important point. This old misconception that fat is just storage. I want to get over that, and let's look at kind of a patient-friendly reality. Adipose tissue, that fat tissue, is the body's largest endocrine organ. I'm going to say that again. Adipose tissue is the body's largest endocrine organ. And by releasing hormones and inflammatory signals that affect the brain, appetite, and pain pathways, this is what typically happens. And I'm going to go over another old misconception, and this is going to be my last old misconception, and that weight loss is simple. It's all about eating less and moving more. That is completely false. I said that on 60 Minutes. I'm going to say that again. The body compensates for weight loss. So every time you go to lose weight, there is increased hunger, decreased satiety, and reduced energy expenditure. So you're not able to burn as well. Medications that restore these signals are often needed. So this is really important. So I think key signal I want to give to people that are listening is that obesity isn't your fault. And it isn't just about weight. It's about how body fat changes your brain chemistry and inflammation levels and even your migraine threshold. And this common thread between obesity and migraine really connect the mechanism, and that's that CGRP common thread. CGRP is elevated in both obesity and migraine. In obesity, the adipose tissue and inflammation increases CGRP levels. In migraine, CGRP triggers that trigeminal vascular cascade, causing headache. Weight loss lowers CGRP, which may partially explain why losing weight reduces migraine frequency. And so I think it's important to talk about that. Now, these key hormones, leptin, adiponectin, IL-6, TNF-alpha are important. So leptin in persons that have obesity is high, and this effect on on migraines. It's pro-inflammatory. It's associated with chronic migraine. It correlates with headache frequency. Adiponectin, which is a hormone that you may not have heard about, is low in individuals with obesity, but is anti-inflammatory, and at low levels is associated with migraine risk. And then IL-6 and TNF alpha is high in those with obesity and lower migraine thresholds and promotes central sensitization. And so if we have repeated inflammation in obesity, it may cause permanent changes in pain processing areas of the brain, which is this periaqueductal gray area of the brain. You don't have to remember that, I do, but it makes the nervous system more sensitive to migraine triggers. And so these shared risk factors between obesity and migraine are shared with also depression, anxiety, sleep apnea, and stress, conditions that amplify each other and worsen the outcomes for obesity and migraine headache. So I just want to stop there because I think that kind of shows some of the overlap between obesity and migraine that many people may not have thought about. So thanks so much for the opportunity to share those common linkages.
Thank you so much, Dr. Stanford, and that was definitely very enlightening information. I think a lot of us here in the migraine world, a lot of our patients are familiar with CGRP specifically because that is the molecule that so many of our treatments target. And so it can be very validating to hear how there is that shared connection and how it's really not the patient's fault and it's not as simple as just lose some weight and you'll get better. On that topic of how this is a complex condition, it can be very difficult to battle these multiple conditions all at once. Can you tell us a little bit more about some of the treatment options that can address both of these conditions together? And then I will also then extend this question to Dr. Halker so she can give us a little bit of a headache perspective about this as well.
Absolutely. So did you want me to go first or did you want Dr.
Yes, go ahead.
Okay, absolutely.
We'll have you go first.
I think that one of the key things that we should be thinking about, and I think this is probably an area that a lot of people are interested in, is GLP-1 receptor agonists, particularly as a novel migraine prevention strategy. Because their effects appear independent of weight loss. There are two small but compelling pilot studies that have been published in 2025 that demonstrate that liraglutide, which a lot of people may not really think about, which is under the trade name of Victoza or Saxenda, reduce monthly headache days by approximately 50% in patients with obesity and treatment-resistant high-frequency or chronic migraine, despite minimal change in body mass index. And the proposed mechanism is novel. It seems to lower intracranial pressure by inhibiting CSF production at the level of the choroid plexus. And this is potentially by reducing, here again, that CGRP release from the trigeminal vascular intervention of the dural sinuses. And this is a first-in-class mechanism for migraine prevention that targets that CGRP upstream rather than downstream. So let's look at this idea of GLP-1 receptor agonists and how they might work for migraine. This traditional migraine therapy of CGRP triggering migraines from that trigeminal nerve activation. GLP-1 seem to lower ICP, which reduces CGRP release from the dural sinuses. CGRP antagonists block receptors peripherally, and GLP-1 seem to prevent CGRP expression. Idiopathic intracranial hypertension, which is not necessarily what we're speaking about today, and migraines are distinct conditions, but chronic migraine and idiopathic intracranial hypertension without papilledema are clinically indistinguishable, which suggests that there's some shared ICP dysregulation. So just to translate that, because I just talked a little bit of medical talk there, lowering ICP or intracranial pressure seems to work, and there seems to be some thought process that GLP-1s may work in this way. The two articles that came out was an article by Braca in 2025 and an article that was an abstract that was published looking at the reduction in headache frequency specifically with liraglutide. And then, of course, there are some additional medications that potentially target that can use. Of course, liraglutide is not as effective as semaglutide, which is a more potent GLP-1 receptor agonist, or the dual agonist tirzepatide, which is a combination of a GLP-1 and a GIP, which is a glucose-dependent insulinotropic polypeptide. And those medications have not been studied, but I presume that they would be even more powerful as a potential mechanism of action to address migraines. Now, there are other medications that have potentially that could potentially be utilized. Obviously, topiramate, which is a medication that is used, is not a GLP-1 that has been shown to reduce ICP through other mechanisms, and that can be utilized. Of course, that's out of the GLP-1 category. Also, zonisamide, which is another medication. These are both anti-epileptic medications. And so I think this is something that needs to be explored more broadly. And I think as we come up with additional use case scenarios for the GLP-1 receptor agonist, dual agonist, and even the triple agonist, for which I serve as the PI here at MGH, that we'll see more strategies, particularly in the GLP-1 domain, for potential treatment of migraine.
Thank you so much, Dr. Stanford. And one of the two studies that you mentioned is actually one of the studies that's published in Headache that Dr. Halker, you're one of the editors for.
Yep.
Would you like to add anything else in terms of how this pertains to migraine management?
Yeah, absolutely. So this is a really exciting topic. There's a lot of interest with these GLP-1 medications and migraine. And to just before I talk about that, because Dr. Stanford spoke about IIH or pseudotumor cerebri, which is just to kind of explain that a little bit. That's a secondary headache problem. So, anytime anyone goes in to see a doctor, a headache specialist for a headache problem, the first thing that we do is to make sure that the person has what we call a primary headache disorder, like migraine, and not something else causing their headache symptoms, which is what we call a secondary headache problem. IIH, also known as idiopathic adrenal hypertension, also known as pseudotumor cerebri, is one of those secondary headache problems. So that's another headache diagnosis. With that, people can experience head pain as well as vision loss. The medical word for that would be papilledema. So that's another headache problem. For that, there is more evidence that these GLP-1 medications can be beneficial. Lots of data coming out from that perspective. But going back to migraine, given that this is what this conference is about, there has been one study published so far. That's one that's by Dr. Braca that Dr. Stanford mentioned. It was published last year in Headache, of which I'm the deputy editor. It was an interesting study, and it goes back to the impact that these medications can have on CGRP. It was a small study. They had 31 patients. All of these individuals had what we call high-frequency episodic migraine, meaning they had at least 8 days of migraine per month, or they had chronic migraine, meaning they had 15 or more days of migraine per month. And all of these patients had tried at least 2 other preventive medications and did not find them to be helpful. And so their doctors thought that, let's try one of these GLP-1 medications and see if they make a difference. And it was really interesting because all the patients, again, got liraglutide, and they were followed for 12 weeks. And again, going back to the fact that these patients did not have that IIH diagnosis, which means that they did not, their eye exam was within normal limits. And over that 12-week time period, all patients had about a 50% reduction in their migraine attack frequency from baseline. So whatever their baseline number of attacks was cut in half. What made this study interesting is that they did not actually lose any weight, nothing substantial, which I think is kind of interesting because I think and Dr. Stanford can correct us, but it seems like a lot of patients tend to lose a lot of weight with these medications. So I don't know why they didn't really lose a lot of weight, but as a headache specialist, what I gained from the study is that these medications can have an independent impact on migraine separate from what it can have on weight loss, right? Because otherwise we'd think, well, is it because these patients lost weight? Is that why their migraine attacks improved? And what we learned is no, it's actually a separate mechanism of action that these medications have on migraine, completely separate from any impact it's having on weight. And again, the limitations of this trial was that they were only studied for 12 weeks. All patients got the active medication, and there was only 31 patients involved. And I did speak to the first author, Dr. Braca, about it. And their next step is that they're going to do a large trial to see if this impact carries through with a larger patient population. But how I've translated this to my own practice as a headache specialist is that next time a patient comes in who has migraine and they ask me, well, do you think that going on one of these medications is a good idea for me? What I can tell them is that it probably won't hurt you, and maybe there's some evidence to suggest it might be helpful.
Thank you so much.
I did want to just address that. So liraglutide is relatively has a relatively low weight loss. So we're talking about 7% on average. That's why we saw really low weight loss with that compared to sema. So semaglutide, we're talking about 15% total body weight loss, or tirzepatide about 22% total body weight loss. So just the comparison of what we would see in a 3-month time span is relatively low, right? That 12-week, I guess study period was, we're not going to see very much. We're going to see less than like Qsymia or phentermine topiramate combination. So this was before we got into those kind of more potent, GLP-1 receptor agonists, when we really started to see a lot of public interest in the GLP-1s, when semaglutide, when we saw the Ozempic, Wegovy's really start to hit the scene. And so that's why you didn't see it. But we see so much in terms of that inflammation change with the GLP-1 receptor agonist, and I think that's why you saw those changes with this particular study.
Very interesting.
Yeah.
Thank you for that. And then let me change approaches a little bit. A lot of times we try multiple medications for people who have migraine, and then we experience either side effects or the medications aren't working. And sometimes patients can just prefer to not be on any medications. Are there any non-medication lifestyle approaches, Dr. Balcer, that you would suggest for patients with both obesity and migraine that can potentially provide them with an additional tool or an alternate tool to medications?
Thank you, and thank you so much for having me today. Just looking around at this room, it's incredible to know that there's so many people who are invested in working to improve their health and wellness. When I see patients in my office, I practice integrative medicine, so my focus really is on lifestyle tools, so nutrition, exercise, optimizing sleep, and stress management. Because I work closely with other members of this team that you're going to meet today from Mayo Clinic, I never tell or advise that individuals forego medications. These medications are transformative. As someone who has this disease, migraine, and until I met this team here at Mayo Clinic, I didn't know that people could feel so well. So I think the medications are such an important part for those when it's recommended, and for people who feel that it's consistent with their values and preferences. What I try to do is give individuals tools that they can incorporate, rather than something that we're always doing to or giving to, things that you can do that you may have some sense of control over. Because for a lot of individuals with chronic illness, it can feel like there's such a lack of control. It can just rear its head at any time. It's unpredictable. What's tomorrow going to be like? So the tools that I stress, and we'll talk a bit about nutrition and exercise, are intended to provide information and help people think about how they can incorporate these into their daily lives in a way that works for them. People say to me, what food should I avoid? And I can't give you a blanket statement, right? Everyone is different with foods that they find may cause symptoms for them. So I encourage people to try to track over time and see, even keep a symptom diary. That can be helpful. And then when you see your neurologist, your headache specialist, your primary physician, you can have a conversation about what patterns you've recognized. The second thing I say is there's no good and bad food. And this becomes really important when we're thinking about weight, right? A cookie doesn't misbehave. A cookie is a cookie. It's protein, fat, and carbohydrates. So it's not good, it's not bad. And I have teenagers, so if you go to my pantry, yeah, there's some processed foods there. There's some chips in my pantry. But overall, it's about a lifestyle that prioritizes real food. And I'm sitting next to specialists here, so I'll let them disagree with me, but it's really about a lifestyle of eating fresh, real food as much and as often as you can. I'll say that what I find is that a lot of people, one of the most common triggers can be fluctuations in blood sugar. So it's really hard when we're thinking about weight loss. Oh, I should skip breakfast, or it's calorie restriction. For many individuals, this can trigger their migraine. So it's more about thinking, how am I going to put together a plate that's going to support my health and wellness, As a 51-year-old woman, that's going to look very different for me now than when I was in my 20s and 30s. Because, and I think you'll hear about it later from our women's health experts, hormones play a huge role in this. So protein, lean protein, healthy fats, and complex carbohydrates in portions that are going to support your wellness goals while ensuring that your blood sugar stays stable.
Thank you so much, Dr. Meltzer. And that's certainly taking a holistic approach to any disease is certainly, one of the things that can provide a huge benefit. Would you like to tell us a little bit more about how exercise plays into this and if there's any advantages of exercise for patients with migraine?
Thank you. So it's very interesting. Apparently, exercise is one of the most beneficial non-pharmacologic, meaning non-medication interventions for migraine.
Yeah, there's been some studies on that, absolutely.
Yeah, absolutely incredible. But I know that for some individuals, exercise can actually trigger migraine. So it's complicated. Our goal.
Yeah, I mean, some people can't get up and exercise because exertion can worsen their attacks, or they are in the midst of an attack to begin with.
So that's complicated. So what do? I think we want to get people moving. So always starting slow, making sure to warm up, that you're hydrated, that the blood sugar is stable. And then exercise can look like different things to different people. So I think that some mind-body practices, such as yoga, can still have beneficial impact for migraine, even in research studies.
Definitely, there's lots of research on that.
Awesome, thank you for that. And then I would like to ask this question to all three of our panelists. What are some tools and resources that are available to those affected by both migraine and obesity that you can recommend for some of our patients? So let me just start with Dr. Helger first.
I mean, I think the American Migraine Foundation has lots of great resources for patients. I'm constantly using that. I think if you haven't looked at that, there are so many great tools depending on where you are with your migraine journey. Lots of great information there. So I think that's a great one to check out.
Awesome, thank you. Dr. Meltzer?
Well, the other part of my practice is talking about stress management and just the idea that with chronic stress, and you'll hear about this later today from one of our other experts, we know that the elevation in stress hormones for some individuals can increase migraine frequency and worsen symptoms. So there are a number of free apps out there, like Insight Timer, for example, where there's guided imagery to listen to. There's a wonderful, you may have to pay for this one, but a headache-specific guided imagery by Bella Ruth Napperstack that I personally love. And so just this idea of trying to incorporate some type of practice daily, even if it's brief, to try to decrease sympathetic drive or that stress response, which is very different than saying I'm stressed. It's really that underlying stress response that causes disruption in some of the stress hormones that our specialists have been talking about.
Excellent, thank you for that. And then Dr. Stanford.
Absolutely. So for patients with obesity, I would say the key resources that are patient-focused are from the Obesity Action Coalition, so the OAC, from the RUD Center, that's RUDD Center. There are patient-focused materials, and from the World Obesity Federation. So those are the three centers that I think are patient-focused that I would use and go to their resources. So the Obesity Action Coalition, the RUD Center, RUDD Center, and the World Obesity Federation.
Excellent, thank you so much. And that's definitely something that I will start talking about with my patients as well. So thank you all. And as we come to a close of this panel, I would just like to ask, sorry, Dr. Stanford.
There are quite a few questions in the chat, and I don't know if we have time to address any of them, but I don't know if you can see them. I can see them because I'm on the screen. I don't know if we have any time to address any of them, but some of them are pretty quick.
We have about 10 minutes. I am not able to see the
I can see
questions
them,
in the
so
chat, but okay.
I can see them just because I'm on Zoom. So the first one I can ask is, one of them is, does obesity only go for patients with overweight, or can one with that looks overweight have obesity, meaning like they have a higher body fat? does that classify as obesity? So I can answer that one. I'll go to the, I'll answer that one. And so I think this is a really important point because BMI is really not a great tool for looking at overweight and obesity. As one of the Lancet commissioners that redefined obesity in January 2025, this was really the key point of not using BMI as one of the key measures. There are individuals that can have excess adiposity, meaning particularly carrying central weight, particularly in the midsection. We know that certain racial ethnic groups, for example, those of Asian descent, can tend to carry more weight in their midsection, but have a quote unquote normal BMI, but be predisposed to higher metabolic health risk, like metabolic associated steatotic liver disease, type 2 diabetes, et cetera. And so it's really important for us not to use BMI as the key measure for looking at overweight and obesity as defined by the Lancet Commission. So I do think it's important. I require waist circumference measurements and anthropometric measures at every single visit for every single patient because of this very reason. And so I really appreciate you, Caroline, at 1:14 p.m. On my schedule, looking at this and bringing up that key point. The next question I think could be to anyone. The next question says, are there any studies combining a CGRP receptor agonist example, and you all may know this drug because I don't, amoxicillin or amoxicillin, do you guys know this drug? Aimovig, okay, not my area. With a GLP-1 medication like Zepbound to prevent migraine, it would seem that using both the CGRP antagonist plus a GLP-1 med is an overkill. What are your thoughts? So I guess I'll pitch that back to one of you.
There are no studies yet, but I think that's an interesting thing to look at.
Okay, anyone else on the, so I guess that's the answer to that question, Amanda. Janice, in the study with 31 participants on GLP-1s, was it the only treatment they were doing for migraines?
Can you say that again?
In the study with 31 participants on GLP-1s, was it the only treatment they were doing for migraines? I think it was.
Okay, in that study that we were talking about from Italy with the 31 patients who had either high frequency episodic migraine or chronic migraine who were put on a GLP-1 liraglutide for migraine for their migraine prevention, they had already tried several different migraine preventive medications and found them to be ineffective. So their doctors thought, let's try this. I think they were continued on whatever migraine preventive medication they were on. But as you know, their treatment was not helping them. So this was their next add-on treatment.
Okay. All right. So there's another question. It says, for a person with pseudotumor, obesity, and migraines, and most of the issues on the first chart, is semaglutide better than tirzepatide? So I guess this might be a question for me. I don't know. So we don't know the answer to this. I would say that tirzepatide is the more potent medication of all of the medications like that are currently available in the realm of GLP-1 receptor agonists. Just because it's a dual agonist, which just makes it more potent because it has a GLP-1 receptor agonist and a glucagon-dependent insulinotropic polypeptide on board. But like I said, these have not yet been studied, but does anyone else want to chime in here?
I'll chime in and say that with idiopathic intracranial hypertension, also known as IIH or pseudotumor cerebri, which again is a secondary headache and not migraine, one of the components of the treatment plan for that is weight loss, whether that is putting people on a GLP-1 medication or bariatric surgery or diet and exercise. Weight loss is a component of that. So I don't think we've really teased out which GLP-1 medication is preferred. It's still something that's being actively researched.
Awesome. Thank you, everyone. Shirley, do we have time for one question from the audience if anyone has? Okay. Yes. Dr. Stanford, if you weren't able to hear that, the question was that you had mentioned that obesity can change pain sensitivity in the brain by altering the gray matter. Is that something that can be changed with intervention or restored?
That is a great question. Presumably, yes, with interventions that address the weight itself, but it's not just the weight itself. When there's a reduction in weight itself, it appears that it reduces inflammation in the body. So with someone like, let's say, that has severe obesity, if we address it with metabolic and bariatric surgery, overall inflammation is reduced. So we see a reduction in TNF alpha, IL-1, IL-6, et cetera. So it seems as though that appears to affect the whole system.
Excellent. Thank you so much. And we have one last minute. If there's no other burning questions, I would just close with asking all our panelists to maybe share one piece of advice that they wish every patient navigating both migraine and obesity was told, but isn't usually told. Dr. Helgersing.
Well, I'll take this back to my clinic last week. So I had a patient last week who has chronic migraine and also was dealing with obesity, who came to see me as a new patient. And that patient opened the new patient consult by telling me that she's sorry she's so complicated. And I think apologized to me probably about 6 times during that appointment. Every time she said she's sorry, I followed that immediately by telling her it's not her fault and to stop apologizing to me. And she said, okay, I'm sorry, I'm apologizing, of course. But then again, apologized again, like a couple of minutes later as she's telling me her story, to the point that I finally, at the very end of the whole appointment, when I'm telling her my recommendations and we're coming up with a plan, I decided to prescribe self-care and also empowerment, because none of us are choosing our health conditions. None of us are choosing what diagnoses and diseases we live with. None of us are choosing our life experiences. And I want to share that with all of you as well. Never apologize when you go in to see your health professional. Okay, none of us are choosing this. And that's what I told her. And that's what I want to tell all of you as well.
That's incredible. Thank you for sharing that. And that is so powerful. Dr. Meltzer.
I'm not sure I can follow that, but I'll try. I'll say this. You know, it's hard when you're struggling with weight or with lifestyle change, or when you have chronic headache disease that is really interfering, you know, with your life, or other symptoms that come along with some of these conditions. But this is a moment in time. And as people in a moment in time, anything can change. And so accepting that this is a moment in time, that there will be a future moment in time when we've started to implement some of these changes to promote our own health and wellness, and things can look very different. Things can look different in 3 months, in 6 months, and in a year. And it's a lifestyle. And that's what these skills are intended to give. It's a lifestyle that will serve to promote your health and wellness one day at a time. And this is just a moment in time. And the other thing I'll say is that for individuals who have not had an opportunity to speak with a headache specialist, or with a migraine specialist, or with a neurologist, however you want to call it, it can be life-changing. Not everybody has access to the resources that we have here at Mayo Clinic. I admitted that, admittedly, but continue to seek the answers and the guidance that you need. It can be transformative.
That's amazing. Thank you. And I love that. Take it just one day at a time, one moment at a time when things are difficult. Dr. Stanford.
Absolutely. Obesity is a disease that you wear. Migraine is a disease that you don't see. Regardless of those two facts, we should not judge a patient. We need to understand what they're feeling, empathize with their emotions, and allow them to be who they are. If we can just take a moment to walk through their shoes, live their experience, feel their frustration, and be who they are, we can be the person they need to be and experience the pain, the frustration, the absolute angst that they endure on a daily basis, to allow them to embrace the joy that's on the other side of this.
Thank you so much, Dr. Stanford. That was beautifully said. And if you can't see the audience here, you're getting multiple of the migraine claps over here as well. I've already run over time, so I won't take up too much longer, but I just want to thank all three of you for being here today and being such amazing advocates for our patients. I really appreciate everyone here. I'm sure that everyone in the crowd does as well, so thank you so much.
Thank you.